poll amongst ourselves, a set of recommendations that we would all like to see in the report that will come out of this conference. And so we're going to need you to really focus and work with us. And I've got a great team of facilitators along with the scholars and our moderators who will be chairing these sessions. I'm going to explain more about exactly how that will work, but I do want you to be thinking already about your long list of ideas and how we'll turn those ideas into recommendations. And by the end of the day, by the end of the afternoon, we'll be inviting representatives of each of those groups back up and giving us their kind of oral report on the recommendations that that group would like to see included. And I'm pretty confident that's going to be a high note on which to end the forum. A few housekeeping details before I also introduce our morning speakers, Don Davies and Mae Katt. Je reconnais bien je reconnais bien qu'on n'a pas parlé beaucoup de français hier, et c'est important que nos collègues anglophones sachent que les écouteurs permettent à nos collègues francophones de parler dans la langue de leur préférence. Alors, for our Anglophone friends, it would be a good show of generosity and bilingual spirit to pick up a headset so that our Francophone colleagues can ask questions in the language of their choice. And moving between French and English when you're up here as a facilitator is a bit of a trick. There was a jarring experience just now, but I want to assure you that our speakers are more than happy to answer your questions in either French or English, and we have our wonderful colleague Joanne over there in the box. Other things that need to be said. Anything from any of you? Any quick comments about yesterday or your hopes for today? Any call-outs of special meetings that this is like the Lonely Hearts Club moment, that if you'd like to huddle with folks at lunch, say, to talk about one thing or bring our attention to an upcoming event, something like this that you want to share, up there at the back.
Hi, I'm Mae. A few of us were talking last night at dinner, and I'm not speaking out of turn on behalf of my dinner colleagues, but I'm speaking for myself. It seemed yesterday, I love academia, spent some time there. It was academic heavy, which is great. We need staff, we need the research and the studies. But those of us that are doing this work on the ground, the nonprofits and the municipalities, could use some loving. but we could also use feeling like we're being really considered in these discussions. So I mean that in the greatest respect and generosity, and we really want to be using all that data and studies to make the magic happen on the streets.
Yes? Thank you. Absolutely. Any other comments?
I just wanted to encourage everyone in the sessions and breakout sessions to not just think about general recommendations about what some outside actor should or shouldn't do in the future, but if possible to think about how such proposals could be turned, such ideas could be turned into actual concrete proposals. And there are people in the room who work with different entities that might be potentially funders or proposers or partners, and so to just try to be as concrete as possible, and if there could be actual, concrete feasible proposals that could be funneled forward to whatever channel after the fact. If it's possible to get there, it isn't on everything. I would encourage people to try to take advantage of the mix of people in the room to at least get that begin.
Great. Thank you, Jen. Any other comments or observations? Sir.
Dans le même esprit, j'encouragerais les gens à faire des propositions, de projets ou d'initiatives auxquels ils aimeraient participer eux-mêmes et auxquels ils seraient intéressés, dans lesquels ils seraient intéressés à s'investir.
Good. Thank you. Nobody had their ears on.
I'm suggesting that people make proposals on which they would be happy to work.
Right. Suggest things that you're willing to do and get involved with.
Along with that, I was struck yesterday that the facilitators continued to ask the questions, what will things look like in 10 years? Which I thought undermined what we want to do as far as action goes, because most of us can't really think about what's going to happen in 10 years. And so if we do want to focus on practical things that we can work on, then we have to think of a much shorter time frame, like what can we do in 6 months and what can we do in 2 years kind of thing. And so the 10 years to me kind of undermines some of the action that we wanted to take.
I'm going to take that comment as a friendly amendment, right? And so in your discussions today, I think it's important not to lose track of the longer-term vision, like where do we want to be in 10 years? But there's certainly things that need to happen now, in the near term, in the midterm, and in the long term. And perhaps if you just apply that as a filter when you're breaking out your recommendations, what's good for today, what needs to happen tomorrow, and where are we trying to get to? Dan, I've got a microphone for you.
Sorry.
Oh, sorry. Oh.
Sorry. Very quickly, I think the reason why we sort of envisioned a 10-year time frame is because some of the approaches to drug policy issues that have been taken have not considered the long-term impacts. So you look at the delisting of OxyContin, the restriction of, of prescription drugs, and the insane outcomes that those have had. So that's why thinking, it's not that we're looking to, create such a long-term vision that things become totally abstract, but that we think through, all the steps from short-term, middle-term, long-term in making the proposals that we're making.
All right.
No, that's okay. Thanks a lot. And I made this point in one of the session yesterday that please, when we are thinking about drugs, please do not forget tobacco. And I'm not just saying this because I'm a lung doctor and I see the wrong end of the stick, the tobacco stick. But it kills more people than anything else. You can put all drugs in one basket, all diseases in one basket. Still, the tobacco basket is very much bigger than anything. So this mistake was made by WHO in 1940s, and they realized it recently, putting drugs in one basket and tobacco dealing with one basket, and that they thought was a very, very wrong decision since the beginning. And we can't go to 1940s now, so let's not make that decision. We had a Health Canada summit of all experts similar to this beginning of the March in Ottawa. That was just based on tobacco, same title, tobacco strategy for next 10 years. And let's not do this, all separately, because they are all drugs, they are all poisons, they all kill people, some more than others.
Is there another hand up here? Just 1 second for the mic, and then we'll...
In addition to the issue of recognizing the important work that's done on the ground by practitioners and policymakers, as well as the academics, that there can be that divide, and we have to recognize that and bring it to the core. I think there's another issue, and I picked up a little bit of it yesterday, on the public health and public safety divide. And if we're thinking about the crisis as it exists today on the ground, or if we're thinking 10 years out, and we're here as representatives from a lot of different spheres, from public health and public safety, I think we have to really recognize that we have to model and mentor and provide leadership about how public health and public safety come together. At the intersection of those, when they're both done well, will be resolution to a good part of this crisis. But if the people that are in this room continue to see and even push and dismiss the other, that's not helpful to any of us today or going forward.
A lot of wisdom up in that end of the audience this morning, don't you think? Thank you for that. I'll take one comment right here.
I just hope today that people who have been living this lifestyle for years or decades voices could be heard more as far as policies that can be implemented. I hope our voices are heard loud and clear.
Getting your morning exercise, Joanna.
Sorry, what was it?
Yeah, just quickly, I'm going to just push what Mark Tyndall said just a little further, and I represent families in BC, well, and across Canada, but we're losing children every day. Young people are children, so that is, for me, and certainly for all of us here, the big reason that we need to look at the short term really critically and hard today as well. Thanks.
Okay. No, I'm very mindful that people came to this forum with a range of motivations and objectives, and certainly we want there to be room in the discussions that follow this morning for you to be able to focus in on the things that you think are most pressing, but also help us to define that longer-term agenda, because we heard from Mary, for those of you who were here last night, we had a great panel discussion. She's seen the very, very slow evolution of many of these policies, and we heard from Elaine as well about how long it takes to really move these major systems. And we want to do some upstream thinking now about how we anticipate some of the shifts a decade or more out. So help us do that, and we'll certainly make sure there's enough room to come up with some clear ideas about what needs doing today. Any final comments? Okay. We have 3 presentations today, Don Davies, Mae Katt, and then at 12:45 we all have to get back here quickly because the Minister of Health, Jane Philpott, will be speaking with us. But to get us started this morning, it's my pleasure to introduce to you the MP for Vancouver Kingsway, known to many of our BC contingent, certainly in the audience. Don Davies is a member of the New Democratic Party, where he serves as the health critic in Parliament. I was also pleased to note that he is one of the apparently 5 most productive MPs in Parliament, as measured. I mean, you can imagine there'd be a number of measures for that, really, but as measured for his lively participation in Commons debates and for introducing a very impressive number of private members' bills. He has been a member of Parliament since 2008. He's a very vocal advocate on poverty and the need for drug policy reform. We're delighted to have him join us this morning. Don.
Well, good morning, everyone. Bonjour tout le monde. It's a genuine pleasure to be with you here today. You know, whenever anybody mentions that I'm one of the top participants in debate, my wife always sends me a text that just says, all that proves is that I talk too much. It really is a pleasure and a genuine privilege to be with you here today to join your thoughtful and important examination of the future of Canadian drug policy. I am also tremendously honored to be in the same room with you, the advocates, the academics, the health professionals, the community leaders, and frontline heroes and heroines who have been so pivotal in addressing not only the current overdose crisis, but progressive drug policy in Canada. I think all Canadians owe a debt of gratitude for your dedication, courage, and compassion, often demonstrated, as we all know, in very difficult circumstances. Your efforts, though, have saved lives, and your work has contributed greatly in shifting public policy and sentiment about substance use in this country. Now, I know that I don't have to situate the importance of addressing addictions or describe the severity of the opioid overdose crisis for anyone here today. We all know all too well the devastating toll that they have exacted on individuals, families, and communities across our nation, and the pressing need for improvement. But I think it is worth repeating just a few numbers to illustrate the scope of this crisis and the fact that progress is not being made or fast enough. Over the last 2 decades, an estimated 20,000 Canadians have died due to drug overdose. Last year alone, some 2,000 people died in Canada, with a record 922 people lost in British Columbia, my home province, alone. And because we know that coroners do not always have the ability to properly assess the cause of death, these numbers are undoubtedly understated. In my hometown of Vancouver, often called the epicenter of the opioid overdose crisis, Fire and Rescue Services reported 162 overdose response calls for the week of March 20th, 2017, just a few weeks ago. That was a 56% increase from the previous week. To date in 2017, there have been 100 overdose deaths in Vancouver. There were 215 in all of 2016, and we're just in the 4th month of this year. If rates continue at this pace, Vancouver will see nearly 400 deaths in 2017. That's double the number recorded in 2016. Now I'm going to pause and say that the government has said that they are making progress on this file, and I have stood in the House of Commons and said we will be able to claim progress only when the rate of overdoses and the number of deaths in this country are going down, and we are not there yet. We expect 50 people to die each and every week this year in Canada from drug overdoses, mostly from fentanyl. So to put it bluntly, there is a human tragedy unfolding as we speak in our society. Now, of course, we didn't reach this point overnight. The overdose crisis has been many years in the making, and there is no shortage of causes. Let me go through a few of them. Our country has long viewed addiction in a stigmatized manner as an individual failing, as a matter of morality or character, and perhaps most harmfully, as an issue of criminality. Our history of cultural oppression of Indigenous people have created a markedly disproportionate rate of substance abuse in First Nations, Métis, and Inuit populations, a phenomenon that has gone largely unaddressed. The medical profession has been slow to study substance use disorder or develop effective diagnosis and treatment. The pharmaceutical industry has pushed opioids for inappropriate use, with the result that last year alone, 19.2 million prescriptions were written in Canada. That's 1 for every 2 Canadians, one of the highest rates in the world. And our political leaders and governments have been blinded by ideology, handicapped by ignorance, and gripped by cowardice. Now, I don't want to use my time today to launch an attack on previous governments' failings. However, I think it must be stated both for historical accuracy and as a warning for future policymakers how damaging the Conservatives' approach to drug policy really was. It can never be sound to ignore, discredit, or even ridicule evidence simply because it does not conform to one's ideological leaning. But that is what they did for a decade. They treated drug addiction as a criminal and moral issue instead of what it really is, a fact of life in modern society, an issue that touches every family, workplace, and community, a product of trauma, and most importantly, a health issue. The truth is that the war on drugs was and is an utter failure, an idea worthy of swift dismissal, if not for the fact that it has been so devastatingly costly in terms of money spent and, worse, lives lost. But in public life, we do not often talk enough about long-term solutions or positive visions about the future. So today I would like to discuss some foundational measures that we can implement to develop more effective drug policy for Canadians. I think these are needed to start the tectonic shift to transform how we think about addiction and to create better policies to address it. First, we must make long-term investments in mental health programs and addictions research. I think it's fair to say that Canadian mental health experts, including the Public Health Agency of Canada, do not yet have an explicit understanding of the relationship between drug and mental health issues. Research identifying these associations will aid in defining the upstream mental health factors contributing to substance misuse. These factors can form the foundation of targeted and proactive mental health strategies, including community-based treatment and support programs for youth. Research shows that 70% of mental illness begins in childhood or adolescence, and those suffering are twice as likely to develop a substance use problem. Effective mental health treatment programs grounded in research have the potential not only to reduce the impacts of mental illness, but also of addiction. In addition, national tracking of comorbidity of mental illness and drug-related fatalities, similar to those in the US and Australia, would enable faster access and a better understanding of trends for the development of targeted solutions. In short, we need to know more, and we need to invest in the science to acquire that knowledge. Second, we need substantial investments in addictions treatment across the board. I mean significant new funding by all levels of government in a myriad of modalities for all distinct populations. As we know, there is an unacceptably narrow portal for access to detox services and an appalling lack of publicly funded longer-term treatment beds in this country. In Vancouver, it takes an average of 8 days to access detox services. That is directly contrary to everything we know about addiction. If someone is willing to get treatment, you've got to get them into treatment right away. If you wait even a day, the moment is lost very often. In truth, effective treatment is really only available to those with the ability to pay or are desperate enough to go into debt to get it. It is not unusual to have to pay $10,000 or more a month to get timely access to quality addictions treatment facilities in Canada, a shocking gap in our so-called universal public health system. This has to change, and we must start building the infrastructure to provide universal access to necessary health services for everyone suffering from substance use disorder. We need different modalities for different populations: treatment centers for youth, for women, for men, for Indigenous Canadians. We must build them like we build any other health facility in this country, and we must cover treatment for existing facilities. It's time to start treating addiction as a bona fide health issue, and that means public coverage for effective treatment universally delivered. Third, we know that much of the opioid dependence and addiction phenomenon has been driven by millions of Canadians who cannot find effective treatment for chronic pain. This must be acknowledged and addressed. Access to multidisciplinary pain management programs, including physiotherapy, weight loss and exercise, nutrition, massage, and counseling, has been shown to improve pain treatment outcomes, as well as reduce the inappropriate use of pain medications, including reliance on opioids. Multidisciplinary management of chronic pain also has the potential to produce significant cost savings in healthcare expenditure by restoring lost workplace productivity and reduced hospitalization. Yet, access to effective interdisciplinary chronic pain treatment currently varies widely by province and territory, is particularly lacking, frankly absent, in rural or remote areas, and wait times are long. Further, the cost is often prohibitive, as visits to non-physician health professionals are paid through private sector insurance or out of pocket, or for many Canadians, not at all. Therefore, we must prioritize the development of multidisciplinary chronic pain centers by supporting provincial and territorial efforts to establish and expand these programs. Fourth, We must expand alternative treatments for people with chronic opioid addiction who are not benefiting from available treatments such as oral methadone. For example, the Salome study found that patients receiving medically prescribed heroin or diacetylmorphine are more likely to live longer than someone receiving methadone maintenance therapy. Incidentally, have you noticed that people are opposed to medically prescribed heroin, but medically prescribed diacetylmorphine is okay? I think we should start using that word more. But despite this, Vancouver's Providence Crosstown Clinic remains the only harm reduction facility in North America where medicinal heroin is used, diacetylmorphine, for treating long-term users. And it's taken an order from BC's Supreme Court to keep its doors open. I went to a talk a few weeks ago at UBC where we listened to 3 former street heroin users who were now being treated at the Crosstown Clinic. Besides their moving personal stories of health recovery, they said that they are asked every day by other users if they can also participate. Tragically, they have to advise that there's no room as the program is fully subscribed. This has to change, and change now. We need to encourage the opening of medically prescribed diacetylmorphine facilities across the country and ensure access to this phenomenally successful program to everyone who qualifies for and wants it. And let's be realistic. These policy initiatives will require a substantial allocation of resources after being chronically underfunded, indeed actively opposed by successive federal governments. Now, last month, Prime Minister Justin Trudeau inspired hope when he personally met with first responders working in Vancouver's downtown east side. He pledged that, and I quote, "We need to come together as a country to help our most vulnerable and recognize the challenges facing, day in and day out, drug users, people with addictions, and those with mental health issues. There are no barriers to the federal government being able to do exactly what it needs to do. We will ensure that there are the resources available," end quote. Now, this is cause for some optimism, especially as it contrasts with the public statements of our previous government. But as former U.S. Vice President Joe Biden used to say, "Don't tell me what you value. Show me your budget, and I'll tell you what you value." Now, I must be frank with you, Mr. Biden was right. Unfortunately, while I acknowledge that the Liberals are espousing better values, their spending decisions do not back them up. Budget 2017, just tabled last month, allocates $110 million to the entire drugs and substance strategy over the next 5 years. $110 million. This is grossly insufficient. Worse, it actually represents a drop in projected spending from the Conservatives' tabled budget in 2015. The Conservatives had planned to spend $556 million on their anti-drug strategy over the exact same time period. So we are seeing an 80% reduction over what the Conservatives planned to spend, as insufficient as that was. And with the expanded pillar of harm reduction now added as an additional funding demand. More problematically for those who want action now, as I do, most of the $110 million is backloaded. While the federal government gave BC and Alberta $16 million, just those two provinces, $16 million, $10 million to BC, $6 million to Alberta, to deal with the opioid crisis alone in 2016, Budget 2017 allocates even less, $14 million this year for the entire drug strategy across our entire country. Now, what the government will say is they're transferring money in mental health along with the health accord, but there is no guarantee whatsoever that that money will be used for addictions or substance abuse research or treatment. The drug strategy is what the federal government needs to fund. Somewhat shockingly, The budget fails to allocate a single nickel in emergency funding for the opioid crisis. Now, this is unacceptable. There is no reason to believe that the opioid crisis is over or under control, or indeed that it won't flare up, particularly with carfentanil now in many communities and fentanyl itself spreading east.
It hasn't even started.
I agree. Now, I can show you in the budget, I can give you the table that shows you exactly these numbers. Now, clearly, none of the policy changes that I've outlined can be accomplished with that kind of funding. They will require sustained focus and dedicated resources over the long term. It will take commitment and not mere good intentions. Now, I want to conclude by talking a little about the elephant in the country when it comes to drug policy: decriminalization and regulation of all drugs. I start from the premise that most of the harm currently experienced by drug users arises not from the drugs themselves, but from the criminalized context which has been constructed around it. Now, that's not just my opinion or feeling, it's simply a matter of evidence. Indeed, the facts are overwhelming that many of the negative health effects associated with addiction actually have nothing to do with the drugs themselves, but rather are brought about by what it takes to feed a criminalized addiction. As we have seen at the Crosstown Clinic, when drugs are dispensed by health professionals in a safe manner, chronic drug users' lives are stabilized. Their health improves. They no longer have to commit crimes in order to acquire the funds they need to buy street drugs. They get access to safer, unadulterated drugs. Overdoses are avoided. They come into contact with drug tapering strategies and indeed recovery itself. These are the facts. They deserve serious consideration at the highest levels of policy making. Now, I have to say this, in case any journalist is listening, no one is advocating the use of drugs or is indifferent to the potential harm they can cause. No one wants minors to access drugs, and we would want all Canadians to avoid drugs or use them judiciously and safely if they must. To the current Liberal government's credit, they have taken some positive steps to reintegrate harm reduction into Canada's approach to drug policy. Although it took a year of hectoring from the New Democrats and fabulous advocacy work by many folks across Canada, many of whom are in this room, they finally introduced legislation to repeal the Conservative C2, the so-called Respect for Communities Act, so that we can make opening safe consumption sites easier and quicker. And the Liberals have rightly pledged to legalize marijuana. However, the arguments that Prime Minister Trudeau advances in defense of a legal framework to regulate and control cannabis could, and rationally do, apply with equal force to all other illicit substances. And yet, on his recent trip to Vancouver, Mr. Trudeau peremptorily and absolutely, it was his word, confirmed that his government will not even consider legalizing, controlling, and regulating any substance beyond cannabis. I believe that, as Canada's elected representatives, we have an obligation to push past ideology and prejudice and fear and engage in evidence-based policy making. I believe it is time we embark on a sincere examination of other jurisdictions' best practices. I think we would be remiss to ignore the experience of Portugal and 25 other countries that have introduced some form of decriminalization and regulation of all drugs. By almost every measure, this approach has been a resounding success, and I believe it holds many lessons for Canada. This is a national conversation that ought to be initiated. Because, my friends, these are not drug addicts of which we speak. They are someone's son or daughter or sister or brother. They are someone's father or mother. They are someone's aunt or uncle or cousin or friend. They may even be part of our own family. I think it is time we rolled up our sleeves, found our inner courage, and start taking bold steps to do our best to ensure that no family has to feel the pain, the loss of addiction if we can help it. Thank you very much.
Thank you very much, Don. I know you're willing to take a few questions, and I'm going to lead off, and then we're going to have the mic circulate here. Obviously, I mean, you're grossly disappointed, I think was the quote in the Liberals' budget with regards to the Canadian drugs and substance strategy, an 80% reduction. What's your account for that decision? Why have they reduced the funding as significantly as they have?
You know, it's always a difficult question, I think, in politics to ask someone to get into the mind of someone else who made the decision. I think, first of all, the government will argue, and you can have a chance to ask Minister Philpott, they will argue that they've expanded money, as I said, under the mental health envelope to the provinces. They'll probably say that health delivery is a provincial responsibility. They may even say that, you know, there's a lot of competing issues in healthcare. I'm not sure. But, you know, to think that next year or this year in 2017, you know, the fiscal federal year is April 1 to March 31. So we're just starting the new fiscal year for 2017, 2018. To have a line in the budget that says Canada's national drug strategy, we're going to spend $14 million, I think next year is $16 million, and the year after is 20. I mean, that's a rounding error in federal budget spending. I think we should be spending, you know, 10 times that amount. In fact, probably more. So I'm sorry, I really can't really explain other than I think it reflects a little bit of the prioritization that this government has given to drug policy in this country.
All right, thank you for that. I see a question right up here at the top, and then we'll come down to the woman with the blue scarf and the gentleman in the T-shirt there. So we'll start up here at the top.
Thank you so much for speaking. A couple of thoughts that I have. When you laid out the points that you believe are important, I would really hope that you would consider some others, which is scaling up harm reduction. I didn't really hear you use those words, whether that be supervised consumption, whether that be outreach, whatever. Another one I think that's important is ensuring that meaningful involvement of people who use substances and frontline workers are involved in the solution, because again, I think that piece was missing in my mind. So that would just be a couple of thoughts that I have.
Thank you.
There's a question right down here.
Just a brief response. I'm a hysterical supporter of harm reduction in every form, and you're absolutely right. You know, I did a walkthrough of the downtown east side a couple of weeks ago, and you know, I walked through the epicenter and I visited the overdose prevention sites that are operating right now. You know, those were triggered and run by peers. And absolutely, we must involve the drug-using community absolutely as a pivotal partner in framing policy moving forward. But I'm a huge supporter of supervised consumption sites, the Salome Project, and other forms of harm reduction.
Thank you. Right here.
Yes, Diane Riley, Canadian Foundation for Drug Policy. I have a comment and a question. You know, under the Liberal government, they had, the previous one, they had a harm reduction strategy, but it was a harm reduction strategy in name only. Under that, more than 90% of the funding actually went to law enforcement. So I think we see a trend. And though I'm loath to say this, that Margaret Thatcher, I hate to even say the name, under her in the UK, we had terrific improvement in harm reduction programming. So that's just food for thought there. The other comment is, because part of the time I work as a consultant for the United Nations for my sins, and I've noticed over the last few years particularly this commentary that we can't give more to the drug program because we have to give it to the terror program. And one of the things I like to put forward is that our communities are much more likely to be a thriving place for producing terror and terrorists and so on if we don't have solid communities that can look at the adverse childhood experiences and so on. But I'd like to see in that budget, what are the lines like on other items that are going towards, for example, these things to do with quote, protecting against terror and so on, because we've got to find where that money can come from.
All right, I'm going to take that as a comment. We have a question from Scott, and then this gentleman right here. Just so that Joanna doesn't have to run quite as far. So first, oh yes, sorry.
Thank you. My name is Scott Bernstein. I'm with the Canadian Drug Policy Coalition, and I'm actually a constituent. I live in Vancouver, Kingsway, and I just want to say that I'm very proud to have voted for you in the last election.
Thank you.
Especially at this moment. Feeling it very much. So
I better stop talking.
Political endorsement.
Yeah, this is not a, thank you. That was my comment.
It's all downhill after this. I'm not talking anymore.
No, you're right, because my question is, I for one was a little disappointed in the NDP's platform around drug policy in the last election, and I'm just wondering, will we see decriminalization and or legal regulation of drugs in the platform, or other kinds of things that support some of the things you're talking about? And if not, or if uncertain, what kinds of things can we in this room do to make sure that that happens?
Well, thank you for the question and for your support. You know, the truth is no party is innocent on this issue. I think it takes courage, it takes political courage to talk about drugs and to talk about, you know, evidence-based decision-making in drug policy. We have, you know, 150 years, probably longer, of a criminalized context, a moralizing context that is a reality in public life. I can't tell you what will be the next platform. I can tell you that there's a lot of us within the NDP who were not happy with our position on decriminalization, who felt that we should be promoting legalization, and who are advocating for more progressive and evidence-based policy. But there are people within our own party, like in all the parties, that are afraid of the issue. I think mainly it's, to be honest, I think it's framed, and I use this word not in a pejorative sense, by ignorance, though. I think a lot of people don't really understand a lot about the nature of substance use disorder. You know, to the last woman's comment about Margaret Thatcher, you know, I'd be happy if we just shifted policy in this country to evidence-based. Take the ideology right out of it, and I'm comfortable and confident that the evidence will actually lead to very progressive policy because it works.
All right, thank you. This gentleman here, and then we'll come over to you.
Hey, Don, thanks a lot. A lot of your policy is spot on, I believe, especially the criminality versus the therapeutic sort of angle and costs in that. I think if you look at what incarceration costs are compared to what, say, maintenance and other therapy costs would be, it would be staggering. But my concern is there's not enough being spoke about as far as early childhood education. When I was coming up in school, there was really no drug education, and that was in place was brought in by the police. And I believe that's a big part of why we went through the opioid crisis that we did, was because of the lack of education. I think we have to start younger in schools now to start educating kids about drugs and correctly. And just like sex, I think we'll see some improvements over the 10-year period you're looking at.
Thank you. I just want to make a brief comment about incarceration. When I was public safety critic, we did a study of substance use disorder and mental health issues in our federal correction system. We went across the country and visited a number of federal institutions, and the number that we arrived at was that 80% of inmates in our correction system suffer from an addiction or a mental health issue, 70% from an addiction. I've also read recently that the most dangerous day for an offender is the day they get out of prison. And that's because we don't have the supports. In fact, ironically, most of the time, part of their parole, almost invariably, it's staying away from drugs or alcohol. Well, tell a person suffering from substance use disorder who's just been in prison the day they get out that they can't use substances without any of the supports being given to them to help achieve that. So you have an endless revolving door. I don't think we have we don't have prisons in this country. We have basically abstinence-based incarceration for people that are suffering from drug addiction by and large. So I mean that's a huge piece of it is to start working with our offenders in the correction system and giving them supports when they re-enter society.
All right.
And I take your point about young people too.
A final question, Donna Mae.
Hi, Donna Mae from the organization Mums Do, and we are the parental voice of drug policy in Canada and international. I want to congratulate you, Mr. Davies. I know that you've taken my calls, or your office has taken my calls, you've answered my letters, and you've worked very diligently to educate yourself on the issues that we're talking about here today. And I encourage you to take that knowledge and share it, or encourage other MPs and other policy providers or facilitators to do the same as what you've done, because you're a prime example of exactly what we need in our government today. Somebody who's willing to learn, someone who's willing to educate themselves, not remain ignorant. So thank you very much. And one further thing, if there's something that you don't know or need to know or want to be advised on, you have a wealth of information just within this audience here. Many of us have traveled all around the world to be able to gather this knowledge, so make use of it. Thank you.
Thank you.
Well, I think that's probably the best note on which to conclude. Don, I know we got you sprung from an NDP caucus meeting this morning.
Liberated,
in fact. We're all delighted that you could take the time to join us this morning and be part of Canada's Drug Futures Forum. Thank you.
Thank you so much for your kind attention.
Next, it's my pleasure to introduce our second and final speaker for this morning, Mae Katt. Mae Katt is joining us from Thunder Bay, where she is a nurse practitioner, and she's going to be speaking to us about some of the cultures of healing and the work that she has been doing with Northern and Indigenous communities there as a member of the Temagami First Nation. Mae.
Good morning. Good morning? Good morning. All right. Here we go. We're in action. I just want to let you know that we've been doing a lot of work in the north that we hope will inspire those who need to get treatment on the ground really quickly. We were challenged by a very serious opiate crisis back in started in 2005. It wasn't until 2010 that we actually looked at treatment options that suited our communities. We're in northwestern Ontario, mainly fly-in reserves, don't have a lot of infrastructure from a health standpoint. So what we did is we had to design and develop a number of Suboxone programs. I'm calling it Suboxone because that's all that was available in Canada at the time. There were no generic. And we've stuck with that because our advice from our communities was that we do low-dose short-term treatment. So we have over 2,000 clients who are on Suboxone in various stages of recovery. This is all under the authority of band councils. We don't have... which is really good, a really good model, because as a clinician you work for the band council, which is really a little bit of a difference. Our nurses, our doctors working in these programs take direction from them, not clinical direction, but certainly what their goals are for the end product for treatment. We've been dealing with over 500 suicides in the last 20 years. It's really hurt our people, lots of trauma. And so we do a lot of grief counseling with our clients, and we use a traditional grief model, which is very easy to do, has great success. And we've also incorporated what we called traditional land-based healing programs. We take our young people out on the land. We do lots of things for them that is very culturally influenced, has the values of our culture and its community values as well. It's family-centered, it's community-centered, and what we see is a lot of individual recovery and people doing very well, and what we're doing is we're really building a stronger spirit. We were able to collect some data. We do over Sulakout zone is 33 First Nations with a population of about 30,000 people. Through the efforts of the Sulakout First Nations Health Authority and the people who work for those communities, we've been able to create some evidence. We call this practice-based evidence. We've read the literature around the world. A lot of it didn't apply because we're not using heroin, and that's where most of the literature was. When we looked at Suboxone, we found that there were things in literature that could teach us things about being able to use Suboxone in our communities. So we call these community wellness indicators. So once we put in this treatment model throughout the northern communities, what we did see was community by community a lot of evidence where things were really improving. So the drug-related medical evacuations, we have to call Toronto to get an air ambulance into the north, and they dispatch a plane. It could take many, many hours to get to the site. And so our nurses, our outpost nurses, our community nurses, are actually the ones who are dealing with many of the crises. They were the ones dealing with the overdoses. They were the ones who were dealing with the suicide attempts and any kind of trauma-related violence. So assault, suicide attempts, overdose, sexual assaults believed to be related to drugs or addiction fell by 30%. The needle exchange dispensing decreased by more than half. And the children and elderly patients were being brought in earlier in illness than when there was a lot of drug use in our communities. Our attendance in community events increased. The sales of food at the local store increased by about 20%. Our criminal charges have fallen by 61%. What a cost savings, right? We have high retention. We've had to do an evaluation on 6 communities where, you know, the lady who held up the urine drug screen yesterday was actually pretty funny, because what we're asked to do is show evidence, right? So the indicator that seems to be acceptable out there is what's the P look like? So we've been measuring P, right? So what it showed us, though, is that we can proudly say, you know, with our intervention, we are actually seeing long-term retention. So 84% after 6 months, 78% after 12, and we're predicting after 2 years we're still going to have 70% retention. The 6 communities that were evaluated saw a dramatic decrease in suicides and suicide attempts. We have 2 studies that have been done from a maternal and child health standpoint, both of those using Suboxone or Subutex in pregnancy, and there's no higher incidence of any kind of malformations of the fetus. In fact, we've been able to avoid neonatal abstinence syndrome with doses of under 8 milligrams, 6 milligrams of Suboxone. So if you can avoid neonatal abstinence syndrome, you're actually avoiding morphine in an infant, and you're actually saving 15 days of hospitalization. Sorry. So the cultural programs that we have really emphasize a group, children, family approach. We use our culture, we talk about parenting, we talk about providing some kind of safety for our young people. You have to remember that our young people were taken into child welfare, they were removed from our communities. When these children came back, they came back angry. And so people said, well, you know, my child needs counseling. And we'd say, well, no, they don't. They need you. They need the nurturing. They need to have some positive experiences. We can replace trauma and we can replace bad experiences by giving children more positive memories and activities. And again, we have respect for all ages. Our elders are big, our elders are going fast, right? I mean, we die sooner and we die sicker. And in some ways, it's because of the health system that's been provided to us for the last 50 years. When we talk about cultural programs, we talk about the cultural dissonance of the kind of health services that we have received. When we talk about community-based healing from a cultural standpoint, culture is an intervention. We know that empathy is an intervention. So when we can use our culture to help heal our community members, we know that we will have long-term success. Cultural resonance is what we're talking about versus cultural dissonance. One of the things I was asked to do was to provide a couple of things that I think would be recommendations. Our pregnant women come down from the northern communities and they see an obstetrician. The obstetrician will send that person to a methadone clinic. They will go on methadone. After delivery, they can't go home because we don't have methadone clinics in our communities. We don't have pharmacies. So now we have a couple of physicians who are saying, let's keep them on Suboxone, let's start them on Suboxone when they're pregnant, let's transition them over to Subutex, and let's send them home. I have 3-year-olds who are still in Thunder Bay who have never gone home to their home communities because they're on methadone. So in some ways, this is the power of medical decisions. Is I'm working in the health profession, I work with a number of physicians. We challenge ourselves every day to provide better care to clients so that we're not imposing our practice, our rules, we're actually dealing with their lives and trying to help them get better. When we look at youth, I work in a high school, I've been there for 14 years. Our school in 2011 had 43% of the students addicted to OxyContin. We had to challenge that. When we looked around for treatment, the only thing offered to us was methadone. So we created an on-site Suboxone program in our school. And happily, after 5 years, we have treated all our students that have come in from the north. Our last Suboxone our last student on Suboxone finished in December. We still provide the service if it's asked for, but we do not have students, high school students now on Suboxone. My last point is research. We have tried so hard to get CIHR grants. I'm a researcher. I've published over the years, and we do participatory action research, but our partners are our communities. We work really hard to answer their questions. And so working in partners sometimes, we get questioned on rigor, and it's like, well, what the hell is rigor, right? So... So you go to the scientific inquiry and you sort of say, okay, this will work, right? So how we adapt and how we adjust, even treatment, the practices that are out there to suit our community and our culture, it works for us. And in other places where you have a community of Aboriginal people, Indigenous, whatever culture, this will work for you, whatever culture you're from, because that whole cultural resonance has a fit with your client. Thank you very much.
Wow, thank you very much, Mae. Any researchers here with a great track record with CIHR who would like to, Yeah? Okay. We'll hook you up. It's good. Let's take some questions from the floor then for Mae. Anyone? Yes, right here.
Thanks a lot for an excellent presentation and giving a flavor of community-based participatory kind of a project. That's what we do here, and we can talk later. But what my question was, you mentioned very vividly how you are losing elders very soon, and the life expectancy is very short. And the fact is, more than 80% people are tobacco smokers, and I don't know what is the prevalence in your particular community, but the smoking rate, and with the northern weather, indoor smoking, so it's a first-hand smoke exposure, second-hand smoke exposure, and third-hand smoke exposure of everybody in the house, elder to the parents and to the kids, causes very big toll on everybody's health, and it's a cumulative damage and most important life-limiting, contributor. So I don't know if you have any proactive measures or you're doing, or if that's not such a problem in your community.
We studied the data of the 63 students who were in our program and who received Suboxone. We're doing a follow-up research, interviews with them, and what we found in that group was 93% of our students were smokers. They were smoking everything. But cigarette nicotine was part of it. But when you go through recovery with a client, they want to change their world. And they also want to look at their other addictions. It's not just substances. I mean, when you think about other addictions, there's a multitude of things out there that an adolescent can grab onto, right? Anybody, you guys too. You're not exempt from addictions. But when you think about how do you help, they have to be ready, right? So eventually we were able to incorporate with our Suboxone nicotine patches. We didn't use Champex or anything like that, but we gave them gum to do. They cut down. And when you look at taking 10 cigarettes out of a body, there's a big difference in health. I mean, what we saw was our sports teams were starting to win again, you know. We were champion volleyball players in our school, and hopefully just with changes like that, we can actually see them come back again and win.
Great. Got a wonderful community indicator right there. I've got a question in the second row.
Hi, I'm Catherine. I'm from Drug Users Advocacy League and Ottawa Inner City Health. My question, well, thank you for coming to present. First of all, it sounds like you guys are doing amazing work, and I really appreciate the holistic approach that you're taking, because I find working in the community, that's what really people want to be doing, is not necessarily even focusing on their drug use, but focusing on their overall well-being and participating in a more meaningful way in their community. So my question, though, is about the Suboxone dispensing. I'm just curious, how is that done? Is it on a day-to-day basis, or are you giving people prescriptions and they can take it as needed? Or I'm just curious about the model of the Suboxone dispensing. Thank you.
Okay, so Health Canada requires us to do daily dispensing despite the fact that we don't have a pharmacy. So we use unregulated care providers. We can teach lay people, nurses can, how to administer medication. They just can't monitor and they can't change the treatment plan. So the communities receive money from First Nations and Inuit Health to do that daily dispensing in our community, which is good. I mean, there's no diversion that way. Clients take 10, 15 minutes to go get their medication at the health center or at the house where the Suboxone program is. One of the problems with what we're doing, though, is Health Canada said we will provide money. It's in the November opioid summit commitments, right? I think the health minister said we will provide funding for daily dispensing for all First Nations in Canada. I thought, great. But what they're not funding are these cultural programs. The places that I work, I'm in 6 Suboxone programs in the north. The Health Canada funded 40% of what the ask was. And so the 40% goes to the daily dispensing, and they have to scramble to find the cultural programming. So we're 60% unfunded for what we need to do for recovery. I know, long answer, sorry.
Mae, we're going to hold it there, but thank you so much. Such a wealth of knowledge with incredible results in the community that you're serving.
Just one point, if you go to Thunderbird Partnerships on Google, you will find information on cultural competency, and this beautiful wheel is there, but there's a summary document that'll explain it. What we hope for all our clients is hope, meaning, belonging, and purpose. No different than what you hope for your clients. Thank you.
Thank you. And let's see if we can't tweet that out under hashtag CanDrugForum, thunderbirdpf.com. All right, now we turn to our work as a forum. And you'll recall yesterday you attended 2 breakout sessions. And I said, life is tough and you got to make choices, because we are about to stage concurrent discussions in each of the 8 sub-theme groups that we had yesterday. And of course, because you can't split yourself in half, you can only go to one of them. And it must be one of the 2 sessions that you attended yesterday so that you can pick up on the conversation, but with a smaller group of people. So in a moment, I'm going to ask for a show of hands for each of those 8 sessions so we can just do some loose load balancing and make sure that we've got a good balance of perspectives and people in those 8 sessions. And if you're joining us for the first time today, then it's a wild card. You can simply decide to go to the theme that interests you the most. When you get there, you will be met by one of the speakers, 1 or 2 of the speakers from yesterday, one of the 2 moderators, and a member of our facilitation team. They're going to ask some pretty simple things of you. You're going to get a card, and you're going to be asked to just write down one idea or action. Everyone's going to play their cards into the center of the table, and we'll start to see some patterns emerge. From that, we'll create a long list of ideas, and over the course of the next 2 hours, you're going to boil that down to 4, 5, or 6 actions or recommendations that you think would make a real impact over the next decade with regards to drug policy. You'll then talk about some of the outcomes that you hope might be achieved if those recommendations were accepted. And lastly, you're going to talk about those areas where you struggled to find consensus as a group. The cards look like this, incidentally, so everyone's going to be able to kind of follow along with what's happening. You're going to get this one idea card, and then there's some larger sheets. What I want to point out, though, is to make this work in the limited amount of time that we've got, we all got to go in there being as interested in listening as yapping, right? And we got to be listening with a real sense of empathy and interest to one another. And I like to say, it's about putting yourself in someone else's shoes. And we should all try on a different pair over the next 2 hours. So if you're going in convinced that the right and only direction is the following, could be true, but let's just make a lot of space to hear the experience of others and to perhaps help them articulate their ideas and recommendations and try and draw together, always be drawing together. And I think the way to do that is to start from where you agree, don't start from where you may disagree. And if you find yourselves at loggerheads, sometimes you have to go back to go forwards. Right? So return to where you agree. Lastly, when it comes to actually drafting some of these recommendations, be as specific as you can. To whom is the recommendation directed? I said yesterday, a recommendation that says public education is important is not helpful. Right? So there's such a wealth of knowledge and experience in this room. I know that we can be impressively precise in our ability to describe the challenge and describe what we think some solutions look like. That's the standard to which we should be holding ourselves over the next 2 hours. So, with that, I'd like to see a show of hands as I call out the 8 sections, just so that we can get a sense of who's headed where. And I know it's difficult to read on our screen now, but I'm going to go not by the subject names, but by the expert names, because folks remember faces pretty well. So how many people are interested in optimizing supply side with Rosalie, Leo, and Stephen? That's a really nice group. That's an appropriate number of hands. Good on you. You guys are going to be headed to E103. All the E rooms are on the east side of the building. You'll find another 3-block tower by some doors just next to registration. And so how many people are interested in discussing continental border control? This is Bo, Kasha, and Dick. Damn, it's all up to you, friend. We'd be concerned if you didn't. We'll come back to this because, of course, he's going to need some assistance. So there may be some other people who have that as a second choice and may be prepared to go there. For Vern White, Jim Pugel, and Mark Tyndall, talking about interinstitutional collaborations between health and health professionals and police. How many people are planning to go there? Yeah, that's... Oh, yeah. So if you're not, let's own it. Okay, so maybe there are a few hands that could find a second option, yeah? But otherwise, you're going to be in the well west. Now that simply means behind the translation booth, right here. That's where you're going to be gathering, all right? And if you find it crowded, just quickly move to your second choice. Now, Meredith Porter and Mary Hogan, System-Wide Shifts in Justice Policy. How many people are headed there? Excellent. Couple more hands, maybe? Couple more hands? Okay. You're going to be right behind the screen here. Then over to Mark Ware and Mark Kleiman. And unfortunately, Mark Kleiman had to leave this morning. He's meeting with Ontario's Minister of Health, Eric Hoskins. So drug regulation opportunities and challenges. How many people are headed there? Excellent. You'll be upstairs in the first of the two rooms that we have set aside. And how many people with Anne and Manuel talking about models of decriminalization? A few more folks maybe? Okay, good, thank you. You're going to be headed upstairs as well, the second of the two rooms further along the corridor up the red stairs. Now, talking about undoing racialized harms with Akwasi, Robin, and Caitlin. Excellent. You guys are going to be meeting just on the other side of that gray curtain here. There's a breakout space there. Equity and harm reduction, Lynn and Andy. Very good. You are going to be headed this way, back through the double doors, beyond the stairs. You'll find the West 101 just beyond Three Box Tower. Now, my friend, border control. Who's going to help out border control here? Yeah.
In the discussion, was that we had to go beyond border control, that it was really about the international dimension of drug policy and focusing on the interdependence of national drug policy regime and how Canada or anyone or any kind of group could help this happen. So it's not just about what to do with CBSA. Okay, it's part of the picture, but there was a broad consensus in the group that, first of all, the whole of government had to be involved, including global affairs and so on, and second, that it was much more the international side of it than just the continental one.
Who's going to join our friend then? We've got a few more hands. 1, 2, 3, 4, 5, 6, 7. Woo! So my friends, you will be headed out down the corridor there to one of the east rooms. My colleagues will meet you and make sure you're in the right place. Now, before you move, know that one of the ways in which we could very easily burn a lot of time is if people kind of drift and chat and then show up and you have to restart the conversation a couple times. So we're only going to take like 5 minutes now in which to use the washrooms, grab coffee, get to that space. You've got until 12:15. You can take a break at some point in those 2 hours, work it out as a group. We will see you back here at 12:45 for Minister Jane Philpott. Good luck. Hey. He is down by the registration desk. I see another set of boxes. Yeah, just down the stairs, keep going straight. Back out on their pride. Yeah, you got it. Add a ton of throw another poster in there. Been here for This high school. Yeah, I think. I don't think
I'm really interested because I wasn't aware of that. I'll be over.
Yeah, we're gonna lift.
We'll start to thank you.
You know what I mean? Okay, thanks.
I will speak up. So good morning and welcome. So for those who may not have been here yesterday. So our speakers yesterday are here again, so thank you very much, Meredith and Mary. And we're talking again about what policy changes have to take place to support better integration and coordination between public health and policing. So, as was described to us this morning, our first task is to fill out one of these cards with one idea. So when thinking about what actions or policies in this area could have the greatest benefit for drug users as well as public health and safety. So let's start with one idea each and see where that gets us.
Right, so I'm just going to walk through quickly. My name is Kate and I'm going to help facilitate. I'm just going to walk through the overall activity quickly so that we all know kind of we're all on the same page. So as Rebecca said, we're going to start by each putting down one idea, and this should be sort of a practical recommendation that we're looking for. And then we're going to come back together and try to form a long list that's going to represent sort of all of the ideas that we come up with. We're going to try and group our ideas a little bit. And then from there, we will aim to create a short consensus list, that's B, and this should be sort of 4, 5, or 6 ideas. So we're going to try and prioritize it a little bit, narrow it down to the top 4, 5, or 6. And then the next step will be to talk about specific outcomes for each of those recommendations, the 4, 5, or 6 that we come up with. And then finally, we will take note of any specific actions or policies that we couldn't find broad consensus on. So if there's anything where we have some discussion, we can't resolve it, we'll take note of it here, and that might have to be our conversation. So why don't we just, does everyone have a card, or just one idea? Yes, of course.
I'm one of the interpreters, so is there anybody who needs help with the because you speak French, or you want me to stay here, or?
Does everyone use microphone? We're all Anglo. Thank you. All right. So let's starting on this one idea.
Can you read again the statement?
The statement, sorry, I'll read it out. System-wide shifts in justice policy and practice to reduce harms and improve treatment and public safety outcomes. Justice policy. I'll write that out.